All my friends over here, and good evening to all those who are in the US. And welcome to this 89th episode of our continuing medical education programs on COVID-19. And I'm very glad that we have an expert in the critical care in the Bronx care who has agreed to come back again. And he spoke to us earlier as well. And he'll be talking on acute care in COVID-19 in ICU as well as the post-COVID syndrome as well. And he will be sharing his expertise with conducting the COVID care clinic, which is the need of the hour, as we also have started. We can take some input as to how it has to be handled from him. I'm very glad that Dr. Sridhar Chilamuri, as usual, has agreed to moderate this particular session after introducing Dr. Venkatram. There may be some new persons here who must have logged in for the first time. I'm sure that Dr. Venkatram is very apt. And Dr. Ram Kairan has put all these talks to us in line so that we will know as to what is happening around the world at this point of time. And at the same time, to look forward to what we can expect in future. And as there are increasing cases in US, the same thing may get repeated in India as well. So it's always important for us to understand the acute care of COVID-19, though we do not have as many cases at this point of time. So I request Dr. Sridhar Chilamuri to take over and conduct the proceedings.
Yeah. Thank you, Sudhakar, and good morning to you, all of you, and good evening to the people in the United States. So it's a pleasure to invite one of my colleagues, Dr. Venkatram, who has been here before, so I actually briefly introduced his talk himself, but I'll repeat it again. Dr. Venkatram has been in critical care and pulmonary medicine for several years. He's an active clinician. He has managed COVID-19 from the very beginning in New York. He saw the main surge that happened in March and April last year, and since then, he's been working diligently with his group on developing new protocols and understanding the nuances of this disease more and more. I think you have reached the same point where the number of cases are down, and this is the time I think it'll give us breathing space to reflect on what has happened, what worked for us, and what didn't work for us. And that is what, so three areas that we asked Dr. Venkatram to comment on. One is any new things and subtleties of managing an acute respiratory failure without dwelling too much on therapeutics. I think that has been covered recently multiple times. And then as you in India have seen a lot of recovered patients who came out of ICUs and medical floors, what happens to them? So since that has happened earlier to us, so we gained a little bit more experience with them, and he has published that data and he's going to share that. And then the looming next problem for both the United States and India would be the winter season that's coming and what effect influenza might. Last year we got lucky, there was no influenza at all in the world, but there is a concern that the overall immunity of the population at large, both in India and the rest of the world, against influenza has dropped quite a bit because we didn't get any exposure to the virus last year. So we are concerned that it might come back a little bit this year, and that immunity being low, that it could become a severe problem. So he's going to share the experiences with COVID and influenza, and then we'll have enough time to take questions. So Dr. Venkatram, go ahead and start.
Thank you very much. Good morning to all my friends in India, and good evening to my friends here. And I'm going to be sharing some experiences in acute care and pulmonary perspectives. What have we learned from the past, and how has the second or the third wave different from the first wave? I would say that the first thing is a very liberal use of non-invasive positive pressure ventilation and high frequency HFOs, high flow oxygens. I remember in the first month of the first surge, we hardly used BiPAP and oxygen. And at around 3 weeks into it, we did have some patients who refused intubation, and we had a few folks who were extubated and who did not want to be reintubated. So we had to kind of rethink our strategies, and I would say with great pride that we were one of the first few hospitals to implement BiPAP and high flow. And there was a lot of thought process that went behind it. We selectively put these patients in negative pressure rooms, and we were good enough to have some HEPA filters, and that's how we actually started using this. But now when we look at the subsequent waves, if you look at the ICU and our pulmonary floors where we have these patients, most of these folks are on NIPPV and high flow. I think when we look at our data set, as we progress in the pandemic, we had more BiPAPs and high flows, but not more than about 15 or 20% in the first data set. But when we look at our new data set, we have at least 40 to 45% of ARDS patients on high flow and BiPAP, and they are doing pretty well. And that's the reason why the mortality of the COVID-19 patients with ARDS has considerably come down in the current wave than in the past. That being said, how do we decide which is better? So that's a $1 million question. It's very difficult to figure which is better, but I can tell you how we do it. There are no clear guidelines as to what to use. We have the trial which said that high flow is not inferior to BiPAP in acute hypoxic respiratory failure. But short of that, we don't have much input. But what we do is, if you're trying to prone a patient, active proning, high flow probably is a better choice than BiPAP because of the problems associated with BiPAP and proning the patient. Not that it cannot be done, but it's probably done better. And we have data on that too that was published it was published in Lancet, the British experience, about 3 months ago. And the one area where we actually favor BiPAP over high flow is when a patient is tachypneic, and if we see some struggle in breathing. So that would be the indication to use BiPAP to decrease PCL, that is the patient self-induced lung injury. That will come into play whether we like it or not. And what's the end point? When would I stop it? Success is a great end point. When patient gets better and you just transition them to nasal cannula, that's no rocket science. That's a great way. But what is failure, especially BiPAP? There has been a couple of publications that looked at it. The BiPAP failures they reported were BMI, heart rate max, respiratory rate minimum, lowest heart rate, respiratory rate that they had, and temperature. These were the 4 values. When they put a composite number, putting in all the 3, they found that in this model, sensitivity was around close to 70% and specificity was also around 71%. So there is nothing actually to guide us. So if I see a patient in our clinical practice in the ICU where the patient is tachycardic, febrile, the rate is going down, then that would be the time we just change them to, we intubate these patients. That is actually the failure. So that's what we are doing. So the transition, we are using more BiPAPs, more high flows. We are using more high flows when we are proning the patient, and we are using more BiPAPs if we suspect patient's self-induced lung injury. And failure is, when all the hemodynamic profile kind of goes south, that would be the time to intubate these patients. Now, the second question is, what about proning? How good is proning in this group of patients? When we first started, proning was very difficult. We had close to 70, 80 patients, and there was no way physically that we could prone any of them. But now what has happened now is we are proning more and more. And if you look at intubated patients, that's no brainer. PROSEVA trial clearly showed that proning does work in patients with ERDS. Even though prone supine 1 and 2 did not show benefit, but in my opinion, PROSEVA did better because they prone the patients at least for 16 hours per day. So as long as we prone these patients long enough, we do get benefit in intubated patients. Now, what about proning in non-intubated patients? If you look at it, actually, this is nothing new. This started in 2015 when Scaravelli looked at a group of patients who were not intubated, but who had acute hypoxic respiratory failure. And he proned them and showed that, hey, proning is feasible and improved oxygenation in non-intubated patients. That was probably one of the first few publications that looked at proning and patients with acute hypoxic respiratory failure and ARDS. And actually, he concluded that awake proning position is a promising therapy. Now, what we have noticed is when we prone them long enough, for proning of non-intubated patients, there are certain caveats have to be met. One, you need a very cooperative patient, and you need a very strict nurse to enforce it. And the enforcement should be at least 16 hours. The way we figured that out, proning is, after dinner, you prone the patient and go until breakfast in the morning. So it means you get a solid 12 hours of proning. And then during the day, we ensure that the patients are prone at least 4 to 6 hours. So that's how we come to at least 16 hours a day of proning. Some patients are very, very cooperative. They do it exactly what you tell them to do. So proning actually works. And in our experience, what we have noticed is extra pillow support actually helps our patients. And we have the last publication that came in Lancet, which looked at non-intubated patients and proning, and they found that the results were very beneficial. So that's what we saw. And now the questions that comes in is, what are the effects on patient outcomes? There is no data which clearly showing mortality benefit, but I think that is there. We all see oxygenation benefit, but if we pull the data of multiple institutions, I'm sure that we are going to see mortality benefit. That's certain, because the sample size in one hospital may not be enough. What is the optimal frequency and duration? In our experience, we prone them until they are out of severe ARDS. We do look at the PO to FiO2 ratios. Again, Berlin definition is less than 100, but we are kind of more liberal. We get them off proning once we are hitting around 150, and that was the Procedure trials cutoff was. And like I said, the duration is at least 16 hours. We don't, we don't prone less than that. And what patients are more likely to benefit? The patients that, like I told you, the more likely to benefit are the ones on high flow. It's not that you cannot prone BiPAP patients, but it's difficult and it's a challenge, but it can be done. Now, the potential adverse events that can act, and the number one really dreaded adverse effect is the patient is prone and the BiPAP mask slips away, or the high flow slips away, more of BiPAP than high flow. So you need multiple watchers, people, you need a nursing, house staff, my residents, and everybody watching these patients like a hawk. So that's what we see regarding proning patients in critical illness. So the difference between the first and the second one is we see more proning because I think we are using more high flow and more non-invasive ventilation, more of high flow than non-invasive actually. And what about anticoagulation? I still remember talking about anticoagulation last time. And we were anticoagulating anybody with high D-dimers. That's because we felt that patients could get into embolic events. And in the first 2 weeks of the pandemic, we did notice some strokes, we did notice some limb ischemias, we did notice some pulmonary embolisms. So this recommendation during earlier days was, we need to anticoagulate these patients with high D-dimers. And since then, many things have flown, much of water has come down the bridge. And you can divide anticoagulation into two main groups, non-critically ill and critically ill. In non-critically ill, the composite data of REMAP, CAP, Active4A, and ATTACK investigators showed that in non-critically ill, using anticoagulation is associated with benefit. And the bleeding risk was fairly low. If my memory is right, I think it was less than 3% bleeding risk in patients who are anticoagulated. So there is clear mortality benefit in non-critically ill. But however, in patients who are critically ill in the ICU, the therapeutic benefits of anticoagulation did not pan out. There was no benefit. Again, this was a composite data of ATTACK, Active4, and REMAP, CAP, the same group and also published in the same NEJM. Both the papers came in together. So there is no point anticoagulating the critically ill. So in the ICU, unless we get to an indication to anticoagulate, we generally don't anticoagulate. That's the paradigm shift from what we were doing in the past to what we are doing now. Now, what about the pulmonary embolism? There's a paradox. I would call pulmonary embolism a paradox for many reasons. It's so difficult. First of all, to make a diagnosis of pulmonary embolism, you are more likely to be right when you think you're right and more likely to be wrong when you think you're wrong. And there is no data to suggest what to follow to say that this patient has PE or not, even in a non-COVID patient. Well score is good. I think it will lead you, but we don't know how well score performs in patients with COVID. We don't know that. Nobody has looked into it clearly. And the incidence varies depending on what manuscript you are reading. I would say that based on whatever I have read so far, the incidence could be between 8 and 16% PE in critically ill patients. That's what we are looking at. Even though one manuscript said it was 55%, but I think it's a lot of PE. That's an overestimate. But this is more of 8 to 16% is where the number is somewhere between these two numbers. And does trending D dimers help? In my opinion, yes, it does help based on the meta-analysis that was done by radiology, which was published in Radiology in 2021. And they showed that in the ROC curve was 0.73. And D dimers between 500 and 1000 gave a pretty high sensitivity, almost close to 95%, but the specificity was low. So that's the take-home message. It's very sensitive, but not specific. So that's the problem when we are looking at D dimers, the role of absolute numbers. And it doesn't end there. Now, we had another study which looked at, is there a number that we can cut off and say beyond which, hey, P is very, very highly likely? This was published in July of 2021, which looked at a relationship of D dimers and prediction of pulmonary embolism in hospitalized COVID-19 patients, not necessarily critically ill, but hospitalized patients. And they proposed, based on their prediction, that about 2,495, this is what I tell my residents and my fellows, 2,500 cutoff. If the D dimers is more than 2,500, you are more likely to see PE. It doesn't mean that if it's less than 2,500, it's less likely, you're not going to see PE, you will still see PE, but you're going to see more P's beyond 2,500. And trending D dimers will help. I think we should trend D dimers. And when would I request imaging when I want to rule out PE in critically ill patient? Number one, like I discussed, is increasing D dimers. Again, the caveat to that rule is, yes, for example, take an example of a very morbidly obese patient. I may just back off not asking it because I may not get to take the patient for imaging. But in any other patient, if the D dimers are increasing, we get kind of paranoid and we do request imaging to rule out PE. That's number one. The second thing where we request PE in our institution is where there is hypoxia out of proportion to radiological findings. You see some patchy infiltrate here or there, and patient is on 80% high flow. So the hypoxia out of proportion to radiological findings will direct us to think of PE. And the other thing that we have noticed is when we get a routine echocardiogram in this group of patients, you do see pulmonary hypertension out of proportion to hypoxia. You have a patient with 30% or 40% oxygen, but you have a huge pulmonary pressure and the patient has no history of anything which should cause pulmonary hypertension. So that's where we are. So is PE increasing? Not really, but there are a lot of PEs that's happening in the COVID patients that we see in critically ill. And ECMO, we could not transport anybody out of our institution for ECMO in the first pandemic because all the ECMO centers were back. They had a lot of patients. When to consider, that has not changed. It is acute hypoxic respiratory failure, severe ARDS, and one organ down only. So that's the only patients that ECMO center is willing to look. And what the ECMO data has shown the ELSO registry published their data around about 6 months ago. And they showed that the mortality of patients who had ECMO was about not more than 40%. So 60% of the patients who went to ECMO are surviving. It's a very difficult data set to understand. About 40% went home or went to a long-term care. About 17, 18% went to a different institution. So we don't know what to make out of it. But even if I say a 50-50 mortality benefit, these are the patients who would have never made it without ECMO, and 1 out of 2 do get sufficiently well to go home. And I think ECMO has not, from the time we took care of patients between the first pandemic and the last pandemic. So in a nutshell, what would I say? What are we doing better in the second and the third wave? Is one, we are using more non-invasive ventilation, more high flows. We are proning more people. We look for PE based on D-dimers trending, and we are getting more echocardiograms to look at pulmonary pressures. So that's the paradigm shift. And ECMO is about the same, has not changed. So I will continue, and I think we'll go to question and answers after I complete long COVID also.
Yes.
So is that okay?
Yes, please.
Okay. Now, we were one of the very first few guys to start post-COVID clinic. And, I would really, the reason we started, the 2 people whom I should really compliment for starting this, of course, is Dr. Chiligmori, and the other one is my friend, Agila Diaz-Fuentes. And I think she just hammered, let's start it. And that's how we started it. And we have a very unique system in our institution. We have 2 pulmonary floors, and most of the COVIDs go to pulmonary floors. And in non-pulmonary floors COVID, they are fairly generous in calling pulmonary consults, so the pulmonary teams are on top of them. And we transition them to our COVID discharge clinic and continue as COVID clinic in the clinic. We have 1 day a week dedicated only for that. So it's not uncommon for us to see about 20 or 25 patients in the clinic. And what have we seen? Very interesting what we have seen. We have seen pulmonary fibrosis. Again, these patients are classically, patients with pulmonary fibrosis are the ones who are discharged on home oxygen, and they come back to us. And my experience is of the patients who went on home oxygen, a good 40-50% of them come out of home oxygen if you give them sufficient time. Generally, about 3-4 months, they are out of oxygen. But 1/2 of them, no, they don't. They are oxygen dependent. And this is a problem. Patient, we don't know how to treat that group of patients, and I will touch base on it a little bit later on. And the second we are seeing is airway disease. We get pulmonary function testing in practically everybody. And when we see a small group of patients who have either obstructive, most common is restriction that we are seeing in the pulmonary function testing. I'll show it to you, the data that we have. But when we have obstructive airway disease on pulmonary function testing, and these are the patients who have no history of asthma, no history of COPD, when we are starting them on inhaled corticosteroids or inhaled corticosteroids plus LABA, these patients do really, really well. And this is what we are noticing, the second thing. And the third one that we are noticing when we follow them up are the patients with COVID who presents to the hospital with pulmonary embolism. I can give you examples of at least 3 patients who were admitted for COVID pneumonia, went home, got worse, and then came back a couple of days later and were diagnosed with pulmonary embolism. And we follow them exactly the way we follow our other patients with pulmonary embolism. We are seeing their spectrum. And the last spectrum we are seeing is patients with COVID pneumonia who were discharged and who have an echocardiogram done, which shows pulmonary hypertension. This is not a big group, but there is a group where you have pulmonary hypertension. Their RVSP was, we either didn't have an RVSP because they didn't have an echo, or an older echo showed a normal RVSP. And now when they come to the clinic and we are doing echocardiogram, after perhaps 2 or 3 months, we are seeing pulmonary hypertension. That's what we are seeing. And what has been our experience? This is, I think this is very interesting. This is the largest data set that has been published so far to date, to the best of my knowledge. So we looked at outcomes and characteristics of patients who were discharged from our institution with COVID pneumonia. Okay, and I'm happy to say that we have a set of around 111 patients. That 111 is missing in the end. We had 111 patients. Now we have more, probably close to 200 counting. And look at the age here. This age is around 60 plus minus 13. This is the group of patients who's coming to us. I think gender, if I have two more on this side, this should be fine. This is not a problem. But I would want you to look at the comorbidities. These are the patients who have hypertension, diabetes, and asthma. This is what we saw in the COVID world about a year ago. So these are the three common comorbidities these patients are having. And some of them had pulmonary hypertension, which is about 25%. 1 in 5 had pulmonary hypertension in this group. And these are the symptoms that are coming to our clinic with. About 1 in 5 are asymptomatic, but a majority of them have shortness of breath and cough. And I would want you to focus on cough, because what we have noticed is a patient comes with cough to post-COVID clinic, even if their pulmonary function testing and spirometry is normal. These are the folks who respond generally well to inhaled corticosteroids. We are seeing that. And rest of them, these are small numbers, but mainly cough and shortness of breath. This is the two main symptoms that these patients are coming with. And this is where it gets more fascinating. If you look at the X-ray, what's happening with their X-ray. So if you look at these numbers and say why only 58 out of 111 had X-rays done during COVID and why only some of them have post-COVID X-rays, the explanation for this is these are our patients who are treated in a different institution for COVID. So we don't have their X-rays. But if you look at it, look at this. You have bilateral infiltrates seems to be more common during COVID, and it resolves and it becomes unilateral. Same thing with the CAT scans. And if you look at pulmonary function testing, majority, 52% are showing restrictive physiology. That's what we are looking at, majority. And please look at this one, impairment in diffusion capacity. Almost 2/3 have an impairment in diffusion capacity. So you have restriction with impaired diffusion. You do see obstruction in about 12%, and a quarter of them are normal. Okay. So now when we are looking at these patients and trying to figure out what to do, the first question that comes to my mind, and we have had this lot of discussion within our own group in the institution, is can we use antifibrotics and when should we use antifibrotics? Can I use fenferidone? Can I use nintedanib in this group of patients? There is no data out there. Outside of a trial setting, there's no point. But the way I look at it is antifibrotics, main use is IPF, and the second use, which is now coming in, is NSIP, secondary to collagen vascular. These are the two main indications for antifibrotics. So till in those two groups, we know what's causing fibrosis. There's something causing fibrosis, so it's ongoing, and using antifibrotics in that group of diseases makes sense. But in patients with COVID, we don't know what is causing fibrosis after the patient has recovered from COVID. Is there some other mechanism? We don't know. Till we get to the bottom of that, I think liberalizing the use of antifibrotics probably is not recommended at this point of time. And if you look at the Swiss Society's recommendations regarding post-COVID clinic, they say practically the same thing. They would not use antifibrotics. But the Swiss Society says that we can use steroids in this group of patients. And have we used corticosteroids? Yes, we have. And there's no dose out there. You can use half to 1 milligram per kg body weight. Again, this is purely, it's just take it out of your head and just give it. That's what it is. There's no recommendation. There is no guidelines to this. We have used corticosteroids, oral corticosteroids. Generally, we have used between 40 and 60. And we are tapering with pulmonary function testing. So hopefully in future, if the data is sound, I will share it with Dr. Chilingmoru, who will share it with you once we get that data set. That's as regarding use of antifibrotics. And how long, we don't know. How long should I use antifibrotics in this patient? How long should I use corticosteroids? There's no answer for that. Thankfully, that group of patients are low. So I think I don't need to use whatever hair I have left to think about that. That's number one. But inhaled corticosteroids and LAVA, I will tell you, if you have a patient post-COVID that you are seeing in the clinic and spirometry reveals obstruction, number one, or if the patient says, doc, the cough is not going away. This is a group of patients where inhaled corticosteroids plus or minus LAVA is going to help. Any combination that you can lay your hands on, that helps. And how long have I used it? About 3 months and counting so far. Some patients got better, we stopped it. you watch and see, whether is the patient getting better or not. But for certain, at least 3 months is what I have used. Is there any guidelines or science behind it? The answer is no. It's based on the experience that we are noticing. And these are the patients who did not have any history of asthma. Now, the third one is duration of anticoagulation in patients with COVID-induced pulmonary embolism. We don't know how long, but I would err in the side of longer duration of treatment, which is 6 months. I generally don't stop them at 3 months. We are continuing them for about 6 months of anticoagulation. And then we repeat the echo at the end of 6 months to look at RVSP. And if the RVSP is high, the first call goes to my colleague, Krim. He does the right heart cath. And we have had a couple of patients with right heart cath. One showed normal pulmonary pressures, despite the echo showing, because there is no major correlation between echocardiographic manifestations. The area under the curve is probably, I think, 0.68 or 0.7. So we do refer patients for right heart cath. So in a nutshell, in the clinic, what are we doing? We are very liberal in using inhaled corticosteroids and LAVA. Antifibrotics is a no. Steroids is a maybe. Duration of anticoagulation is 6 months. Yes, we repeat echo in all of our patients at 6 months after PE to look at RVSP. And if it's high, we refer them for right heart cath. That's where we have. That's what we have. And this is very interesting. We had a very lively conversation about a year ago when COVID was coming down. I think Dr. Chemoli was in June, July when we had this conversation. We said, hey, this fall we're going to have two things. We're going to have influenza and we're going to have COVID both hitting us. How the hell are we going to prepare for that? And the group was divided into two. One group felt that there's going to be dual infections and we're going to have more problems then. And one group felt, hey, because everybody is wearing masks, maybe we are not going to see that much flu. And the second group actually was right. And this is the publication that we did about a month ago. This was the change in patterns of hospitalization for influenza during COVID-19 surges. Very interesting. I just wanted to focus on this slide because this slide gives more information than any other slides. Look at it, we trended 4 seasons, 2017, 18, 18, 19, 19, 20, and 2021. 2019-20, that was the COVID season, which started around March, February-ish. I think we had an overlap. The first half of that season was mainly influenza. Second half was mainly COVID. If we missed a few influenza, actually, no, we did. We were swabbing everybody and we were getting dual infections. We did see that. Now look at the two before. The state had 126,000 cases. Then the following year, it was 106,000 cases. Then it was 157,000 cases. But look at the number of cases in New York State. 2020-21 is 4,460. This is incredibly low. And if you look at our county, that's where we practice. The numbers went down to 150, from 20,000 to 150. And in our institution, during the pandemic, half and half, pandemic, COVID and influenza, we had 187 cases. Now we had only 6 last year of proved influenza cases. And we continued to do the same number of tests, more or less. We had the same number of admissions, more or less. And we had the same number of influenza tests per 100 admissions. The p-value was not statistically significant in any of this. And this, when you look at demographic comparison, it was practically nothing, nothing much changed in demographics. And if you look at it, D-dimers, you would intuitively think that we weren't doing too many D-dimers in the past. No, we were doing. And if you look at it, the D-dimers didn't change. The p-value doesn't change much. Kidney function was more or less the same. And none of these parameters showed any statistical benefit. And when we look at all the patients of influenza, this was a multivariate analysis that we did to find out if existing COVID infection increases mortality in patients with influenza. So it means if patient has a dual influenza and COVID, are they more likely going to die? So that's why we looked at the mortality model, but it did not. The standard, mortality risk factors were, of course, if you were in shock, if you are mechanically ventilated, if you had a secondary bacterial pneumonia on top of it, if you had a poor EF And, this is very interesting. If you had a normal chest radiograph and you're admitted to the ICU, your chance of mortality is 0.4. It makes complete sense. And ICU admission itself was associated with increased mortality. And that's where we are now. We will be facing the next influenza season. We have started vaccinating about a week back. It's very interesting to see what happens. So one of the hypotheses that we had as to why we didn't see that many influenza when we had a COVID season was probably because of viral interference. That theory has been going around and around. Maybe that's what it is. One virus doesn't, virus, hopefully they're very territorial. They don't want the other virus to come in. Maybe that is true, maybe not, but that's what we saw. And I'm done with this, and I'll be happy to take any questions and answer to the best I could. Thank you.
Yeah, I think somebody asked access to your article. I posted the PDF. It's open access, so they should be able to. So I put the PDF on the chat window if they want to take it down. You want to go to Prem Kumar now and have his comments, and then we'll go to question and answer. Go ahead, Dr. Prem Kumar.
Prem,
Yeah, we're
proceed.
waiting.
Lucid exposition, Dr. Venkatram, about your experiences and how do you eat in ICU. Actually, I've made a set of questions so that, am I audible?
No,
Yeah,
Prem,
you're
is
audible
bad.
now. You could start now. Yeah.
Am I audible? Okay.
Yeah.
So actually, Venkatram, did you cycle between HFNC and NIV anyway? That I mean to say, a patient is kept on HFNC for some time and later on NIV and back to HFNC like that to improve the compliance and to reduce down and all those things.
That's a great question. That's a real life question. Yes, we did have that kind of situations, and this would what would happen if the patient was on high flow, and on high flow, if the patient is getting tachypneic and tachycardic, one of the things that we did was use BiPAP, and in non-invasive ventilation, we felt that this was causing patient self-induced lung injury. So what we would do was we would go with the higher EPAP to maintain oxygenation, like using it as PEEP, and then use IPAP over it. So generally our numbers, the usual setting, the fellows know this very well, was 18, 8. So we would get at least 8 of EPAP and would get 10 of pressure support and use 8 and 18 till the patient gets better and then transition them back to high flow. So we have done that. We have seen patients who are both on high flow and BiPAP. And one great equipment that you can have, that we have in our institution, is we have one machine which can give both BiPAP and high flow. So it's very easy to cycle between the two. So whenever we see a situation like this, we ask the therapist to get that machine so that we can use either BiPAP or high flow depending on how the patient is doing.
Actually, here in India also we have one machine, Mindray ventilator, which can switch between both these two.
It's been the same experience. I think it works pretty good.
And did you find any difference in intubation rate between HFNC and NIV?
No, not really. I can't tell you but the answer to your question, I will probably have in about 6 weeks' time. We are looking at all the critical care admissions and trying to compare the first pandemic with the second and see if there was any decrease in intubations. That I can tell you later on once we analyze the data. But out of what appears to me when I think of the past as to what has happened is, I do firmly believe that we were responsible for eliminating so many intubations. You know, if you look at the old world, when we were actually, before, I shouldn't use the word old world, pre-COVID world, if the patient was on 60, 70% FiO2 on BiPAP, that would be the time just put the tube and intubate, right? That's how it used to be. But in the COVID world, what has happened now is we have patients on 70, 80, 90, or sometimes even 100% FiO2 on BiPAP, and we are able to transition them slowly back to a lower FiO2. So the amount of intubations that has happened definitely, I think, has gone down by the use of BiPAP and high flow. But to give you the exact numbers, a few days from now, once we analyze the data, I can let you know.
Right. Thank you. And regarding intubated patients here, a few patients, their respiratory drive is so much, they are pulling their tidal volume to 850, 900 ml, and we are worried about the ceiling. And how do you manage these intubated patients pulling large tidal volumes of 800, 950 like that?
Oh, number one is heavy duty sedation, very heavy sedation. We maximize fentanyl, and after we maximize fentanyl, we do Aspicidex, and we are kind of not so liberal on benzodiazepines. We are more of propofol, but what we are noticing with propofol is triglycerides going up and putting the patients under risk for PRIS. So what we are doing is, in that group, we are using benzodiazepines, but we do use heavy sedation till that phase is over. And all patients with moderate to severe ERDS, the cutoff is again 150, are paralyzed. We are using neuromuscular blockade for 48 hours. Yes, Acquisys trial did show the decrease in mortality, but there was a recent publication 2 years ago which showed no benefit. But we are liberal in neuromuscular blockade. And I think if you handle the first 48 to 72 hours is when we can get them off. I can give you one example, like we had last week. A young patient with ERDS, non-COVID ERDS, PO to FiO2 ratio was 90. 2 days of neuromuscular blockade, proning the patient. Now the PO to FiO2 ratio is 220. Just 2 days. So, but heavy sedation plus paralysis.
Okay, Dr. Venkatram, regarding weaning, a lot of people keeping in view of the high intubation, re-intubation rate, the weaning criteria have become a little more stringent. Like, spontaneous breathing earlier was around 2 hours, and now some people are trying at around 4 hours. And pressure support earlier at 8 pressure support, if the patient is doing good, we used to wean off. Now it has come down to even 0 to 5 pressure support. So that pressure support or the duration of spontaneous breathing trial is longer. And what's your practice there?
Our practice hasn't changed. No, we don't take the pressure support down to less than 8, because okay, the smallest ET tube that we're going to have is probably 7 or 7.5. And if I get the pressure support down to less than 7 or 8, then the patient is now breathing through a straw. So we will not do that, number one. And two, we have our share of post-extubation failures too. To prevent that, it's our practice that post-extubation, everybody goes on BiPAP or high flow. Every patient who's extubated, post-COVID extubation goes on BiPAP or high flow, unless the patient is looking golden. That's kind of rare, but otherwise you just treat them as high risk and put them on. And we are able to salvage quite a lot with that, like that.
And the coming two questions are both for you and Dr. Chilmuri. And how did you cope up with the surge? In the first wave, we were scampering through in our ICUs. Tens of patients gasping, and they were brought and left at the doors of ICU. People used to just leave them and go. That was the scenario in the first wave. And another problem we faced is 4 or 5 patients with the same name, Apara or Krishna Rao, and very difficult for the identification. We don't have, we didn't have the tags. Even now also, we don't have the tag system and all. And, there were situations where one body was handed over to some other's relative, all real problems what we faced. How did you cope up with the surge regarding this personnel, equipment, logistics, and finally, these identification issues in the ICU?
Dr. Chilmuri, let me take that. I think you should take that next, second. You can shut off your screen. And I'm very sincere when I say these things. The planning in our institution, when I say institution, I mean Department of Medicine, started way before the COVID surge, probably February. The man, you also addressed this question, he was hammering everybody every week talking about this. This is what's going to happen. This is what's going to happen. Chilmuri was in our head every week. On Thursday, that was what it was in the meetings. This is what's going to happen. This is what's going to happen. Be ready. Ding, ding, ding. That mantra started 1 month before, so that we were prepared. And two, the scheduling changes were made in such a way that nobody is overburdened. For example, we decided in our team, critical care division, that pulmonary critical care, that 4 of us will focus on the ICU and the remaining will focus on non-ICU critical care, which is in our pulmonary floors and other floors. So we did a 4 on, 3 off, and 3 on and 4 off. That's how we were working. And then on 3 days that we weren't actually doing this, we were doing telemedicine, helping our colleagues to take care of it. And then out of nowhere, Chilimuri got more critical care beds. You know, PACU, there's no operation, so we grabbed PACU. So more critical care beds went there. They were not doing endoscopies. We grabbed that area, we put more ventilators there. So suddenly you find that we are a 26-bed ICU, and this 26-bed ICU expanded like there is no tomorrow. We grabbed 11 CCU beds because there were no elective cardiology cases coming in. So we had 26 plus 11, plus another 14 to 15 in PACU, and another 6 in endoscopy unit. And that wasn't enough for him. He started more critical care beds in 11th floor. There was a one open area called as, what is that? 24-hour admission area that we took over. And to help us, most of our colleagues, not more, actually all of our colleagues are. I still remember my GI colleagues, attendings, working in PACU, taking care of patients. Any problem they would call it, but we would be the backup and we would be telling them. And we had all the other specialties who were manning there. And we promoted our 3 senior fellows as attendings practically. So we suddenly had 12 attendings, and 3 fellows who were incoming fellows, we promoted them as fellows. So we had 6 fellows. So 6 fellows plus close to 12 attendings, we suddenly had a group of 20 to take care of. And the movement was seamless. And somehow we got more vents. We figured a way. In the initiative, WHO said, don't use BiPAP. So we have one very smart person in our group called Dimitri. His name is Dr. Lowaski. He figured a way how to convert them into ventilators. Like 15 minutes is all his brain took to convert them to ventilators. So resources, we didn't have a problem. So when the patients came in, we were ready. So that's what I could tell you from my side as an insight working in. And for the residents also, the way they managed the scheduling made it easy for the residents. So I think we were stretched, but sufficiently unstretched to tide over the crisis. That's how it was. Dr. Shinimo, it's your mic.
No, I think he covered a lot of that. So on top of what he just explained, we kind of created 4 groups of clinical teams. So the first one is the super users. I would call those would be people who trained in subspecialty of pulmonary and critical care. So they were not asked to manage patients on a daily basis. So we asked them to be super consultants on all the floors wherever they're critical care beds. So we had a second team who were actually trained by them quickly, and all of them had, they're all internal medicine specialists, but they may not know enough ventilators. They have fair degree of comfort with critical care though, but we quickly did a training by the super specialists to tell them the basics of ventilators and what to watch out for. So that was the team 2. And the team 3 are residents who kind of are assigned a limited number of beds, and their shifts were very limited. And then the senior medical staff who had medical problems, and we didn't want them to be exposed to active COVID cases, we made them the people who will communicate with families and patients on a daily basis. So, you know, because you're isolating patients and not allowing visitors, you obviously, patients don't get any information about what is happening with their loved ones. So we made it a point that somebody has to call the family and tell them what is happening. And so senior physicians who were at significant risk to get COVID and have a deleterious effects from it, we said, don't come to the bedside, you do it by phone. You'll have access to our electronic medical records. You see them and then report to patients what is happening with individual patients. We took administrative staff and asked them to identify patients all the time. You said about duplication of names, and we had similar problems. When if you see a lot of Apara, we see a lot of Rodriguez and Gonzalez, and they were coming as in large numbers, as the way you pointed out. So we had people from the administration staff. These are all people who do the basic registration of patients, people like that, to regularly go through the floors and do a reconciliation of who's on what bed 3 times a day. So every shift, the clerks from the admitting office would come in and check what patient was there. We did struggle with many patients where names were unknown, because the EMS would go to their homes. They would be in respiratory failure. They would just intubate, bring them in, and we really don't know who they are. So there have been tragedies where people died with their names never known. So I think this is the time for us to reflect and do an autopsy on what we did right and what we didn't do right. And I think one of those exercises is what he presented to you today. So I would want the pulmonary specialist to reflect on the ventilator care and the critical care of what you did last year. And in India case, what you did earlier this year. Did it all make sense? What can you change, and what needs to happen? And I think in each hospital, it's a different autopsy that you have to do. In India, I think one of the focus would be, why did India end up with so much mucormycosis, would be a question that we have to dwell into and answer. I think this lull that you get is time not for all of you to relax. Of course, you should take break, you should take vacations, but it's also a time to reflect on what worked and what didn't work. And we're still learning. I think only 2 days ago, Venkatraman and I debated over the D-dimer rises. What's the best way to use a rising D-dimer? And so that sort of, thoughtful discussions at every level. What cardiology did they do enough echoes? Or did the dialysis people, did they do enough dialysis? I think you need to do that, because it's still a disease that we don't know a lot about, and there's a lot of learning in the process. So I would say all of that, and I wouldn't say I know the answer how to deal with the next wave, but I think we've learned a lot, and at least we'll limit the mistakes we made last time. So go ahead.
Dr. Chilimuri, actually our PG education had a big hit, at least our pulmonary division. The reason being, before COVID, we used to see a variety of cases, and postgraduates are, they got an access to see all the variety of cases. Now, our hospital is made into a COVID hospital and still not made a COVID plus other respiratory. Still, it is COVID only. So for the last 2 years, the PGs are seeing only COVID, and people are also thinking that this is a COVID hospital. They're, scared to visit this hospital. So how about your department there in pulmonology department? Is there any difference between pre-COVID and post-COVID PG education?
I could tell you that we do have fellows. Yeah, we do have fellows. Yes, for the first maybe March, April, and perhaps some May, it was predominantly COVID, and not it's only COVID and nothing else. And after that, all the diseases have started coming back. To give you an idea, we do close to 70 to 80 endobronchial ultrasound, and the fellows do probably 25 each every year. But we lost some EVAs for 6 months, and now they're all coming back. Lung masses are coming back. So I think the fellows education haven't suffered much. And the clinics haven't changed at all. I think they've gotten better. The bread and butter pulmonary still exists in the clinic, but post-COVID clinic is a good challenge. So I think our fellows in training are doing well. No problem.
Dr. Venkatram, here in the post-COVID, we are seeing a lot of lung cavities. And when we did BALS, most of them showed Acinetobacter, Klebsiella predominantly, and some Myocar and Aspergillus, but predominantly 80% Klebsiella and coming almost resistant to all the drugs. What is the scenario there?
No, nothing like that. It's been pretty much no difference between pre and post COVID regarding BAL. No.
Okay, cavities are not seen post-COVID scenario.
No.
All right. Right. Finally, in the second wave, we had a oxygen crunch. Do you have any advice for us to how to conserve oxygen this way? Anyway, the government is very keen and it is setting up PSA plants, everything like that to overcome that difficulty in the third wave. But do you advise us in any way to conserve oxygen from the doctor's side in the ICU?
We didn't have any shortages, so I doubt if I can give you a real decent answer regarding that. No, we had no problem with oxygen.
And
I think,
I'll end this with, sir, please go ahead, sir.
No, I think the oxygen shortage, firstly, India is a net exporter of oxygen. I just want to clarify, India used to export oxygen to the entire world. So I think the Indian oxygen problem, firstly and emphatically, I think the doctor should not be conserving oxygen. I think that is unethical, and you don't want your pulmonary critical care going into battle with the hands tied back. You don't want to do them. Let them save as many lives as possible. I've never asked them to do anything to compromise the care. I think you do that, you tell a doctor to compromise this and select this over that, they will be disheartened. And number one, they won't be as functional as they need to be. And I know my team, they did an exceptional job. And I feel that's because they always were well supported and never were asked to made these difficult non-clinical choices. They were never burdened with that. And I don't think you want to do that either. I think India's oxygen crisis to some extent happened in the United States, in Florida and Texas now. I think both India and United States and every country that got Delta grossly underestimated how rapidly Delta variants will spread. Like the attack rate is so high that we all underestimated it. And that's what happened in Florida. Some hospitals could not, it came down to 1 day of oxygen left. That never happened anytime in the US. I think we've learned that lesson now. We know that a variant like that could spread massively, and you can't underestimate it. So hopefully, I don't think India will face a similar crisis again. And the fact that we vaccinated so much now, I don't think you'll have it. So I hope you'll never have to make that decision again where you're going to conserve oxygen from one patient to another. You'd never want to be in that situation. It's difficult to manage. It's very disheartening to function like that, especially in a crisis. You want to feel like you're saving lives. And in terms of medical education, you were saying how it got compromised. Actually, there's a big rebound of what you actually see. We see a lot of variety of cases now once the wave settled down, because many patients didn't get enough care of the regular medical problems. As a result of that, we're seeing a variety of amazing cases. That's number one. COVID also kind of activates a lot of autoimmune illnesses too. So we're beginning to see that too, because a vast number of them have anti-nuclear antibodies. So we're beginning to see more of autoimmune diseases now than we saw before. So medical education as a whole did not get compromised. Yes, 3 months it was mostly COVID. But after that, it's now a wide variety of problems. Actually, they're learning more now, I would say now, than they learned even 2 years ago. And I think when you're managing COVID only and nothing else, it's very important to tell the doctors and the staff that they're saving lives, that this is okay if it's all COVID, but you are saving lives. This is why you became a doctor, and repeatedly count the number of people who made it through ICU, made it through ventilators, and went home back to their families. I think this is very important. You share with your staff, these are the lives you saved. Because the world is showing how many people died all the time, and you don't want to. We saw that, and the doctor sees people dying. You don't want to reflect that on that much. Reflect on how many people you're saving. That kind of drives people to keep doing it, and then the waves settle down, and then you go back to your regular day-to-day medical problems that you have. Anyway, I think that's how I would view it.
Dr. Chilimuri, conserving oxygen, I mean to say that preventing wastage of oxygen. What we see in the wards is, people on HFNO high flows and not making an attempt to reduce them, or if a patient is dead, still connected to the ventilator and it's, pushing on oxygen and all such because in large number that will matter. That's what I mean to say. And
I agree.
That's
I agree.
And,
I think if a patient has died, there's no point in continuing a ventilator. I think that's a waste. That should never be the situation, not just during COVID, anytime that shouldn't happen. Don't you agree? I think the processes, this is what I meant that when it's time to reflect on all your processes. Okay, this is your process. When a patient dies, you quickly switch off the oxygen valve and disconnect it. That should be a process in place, COVID or non-COVID, and always should be. I think these are type of processes you should look at and save. And while you're talking about oxygen, I think one other area that you want to focus on, that when you have all these high flow patients, high flow oxygen patient all over your ward, you have a tremendous fire hazard in the hospital, and you need to watch out for it. I went through floors and talked to each of them, understand that all these high flows that are going on in this floor, a single spark will ignite a fire. So went through fire drills, what to do when there's a fire. And certainly many hospitals all over the world had fire accidents during the COVID crisis, because there's so much of oxygen flowing all over the hospital. So I think you may want to look at that drill too, your electrical circuits, and make sure that you don't spark a fire, because it'll be dangerous with all these high flow oxygen. So you may want to look at that aspect of your training too.
Okay. Dr. Venkatram, I'll end this interview by making a comment. Recently concluded European Respiratory Society Congress on September 3rd to 5th. There was a debate in the pro and con for the antifibrotics in COVID fibrosis, and the basis is COVID fibrosis is sharing some common pathological 6 levels or WBC telomere length, and matrix metalloprotease 7 MM7 levels, and gene 50 gene signatures. So they have studied some, and they have genome-wide association study, IPF and the COVID fibrosis. So there is a French study known as Nintecord. They are, after 2 months of COVID recovery, they are recruiting nintedanib versus placebo for 12 months, and they're looking at it. And another study, PINSER, that is from PGI Chandigarh, pirfenidone versus nintedanib. They are, recruiting for 24 weeks of, nintedanib versus pirfenidone about this. So this is something about the pro of the pro-fibrotics, and the con debate. Some other doctor from Switzerland, she said it is not the pro-fibrotics, but you have to attack at the level of inflammatory cytokines. So you use immunomodulators at that point of time rather than using antifibrotics later. So this was the essence of the pro and con debate. And thank you so much, Dr. Chilimuri, Dr. Venkatram, and Dr. Kairam for giving me this opportunity to learn a lot of things from you. Thank you so much.
Thank you.
Venkatram, you want to comment on those studies, or
yeah, yes, we are closely following those studies, number one. And if you go to trials.gov, there are more studies on the making. And I know of one study that's happening in New York City regarding the same thing. I think time will tell. Probably in the next 6 months, we'll have an idea as to what's happening. And I hope that antifibrotics will work. And if it works, it's going to give us one more ammunition to help our patients. I do hope it works. We are also closely following the studies. Thank you.
Yeah.
Thank you so
Ram,
much.
go ahead, ask questions, Ram.
Yeah, I was repeatedly asked a question during the peak in India about people ending up badly becoming respiratory cripples becoming candidates for lung transplant. Dr. Venkatram, in your experience of the survivors, you have had some or a couple of lung transplants or not yet?
No, I cannot think of any patient who we had to refer for a lung transplant. No.
But you have some serious respiratory cripples.
That is true. So if you look at it, quite a few of our patients who survived were on ventilator support. We couldn't get them off the vents, and they went to long-term ventilatory nursing homes where they can take care of them. And we can tell you that out of this group of patients who went to nursing home, we have been fortunate enough to get a few of them off the ventilator, but not all of them. So we do still have a lot of them on ventilator. Yeah.
Yeah.
When you were beginning to describe the experience, how the hospital handled, you were saying to Dr. Chilamuri, you can turn off your video for a moment because he's not bashful, but the truth is the guy did an incredible job. So I wanted to ask you, between the two of you, during this entire 17 or 19 months, what is the total number of COVID patients in Bronx Care? About 2,500?
No, 6,000.
6,000 COVID alone, admitted.
Yeah.
Wow.
Yeah, in terms of that lung fibrosis, I just want to comment. I kind of like follow a rule of 1/3. So 1/3 actually get better on their own without you doing anything, and they seem to completely recover. And 1/3 just stagnate like that, and that's the group that Venkatram was talking about. And another 1/3 actually come back within a month, 2 months, and actually go down rapidly and never make it, even though they've survived the ventilator and went home. But they kind of come back within weeks and just go down rapidly, get a secondary bacterial infection and multiple other infections, and don't make it. So I think one of the things we have to figure out is what is this 1/3 who recovers, so we could leave them alone and just give support, and the 1/3 that you need to intervene. I think that we still don't know. And so I'm worried about the clinical studies that if you put all of them into one group and attempt to treat, you will not get the results you need to do. I think we need to analyze a little bit more, understand which groups, those subgroups are important to pick. Otherwise, I think some of these studies will fail, not because the drug is not useful, but just because you put the wrong people into the study group.
Of the 6,000, how many died?
520 or so died. So even as we speak in the United States, the death rate of overall admitted patients is about 12%. It ranges from 8 to 12%. A vast number of them are unvaccinated, 99% or so. And they have major risk factors, obesity being one of the biggest ones, and have heart disease and things like that. So I think the big change that we've seen is the healthy people who get severe disease now no longer die from COVID. And people who come late with bad markers like high LDH, high D-dimers, high ferritin and CRP level continue to die in the United States and I think rest of the world too. And I think if they come early when they become moderate to severely ill, so if they come 7 to 10 days after onset of illness, they tend to do well. And if they come 14 days after onset of symptoms, they don't do so well. I think that's what we're seeing still. That hasn't changed much.
You two are very nice gentlemen, very kind. But today I was watching the Oklahoma-West Virginia game. There were 110,000 spectators in a college football game. None of them were wearing a mask, and vaccination rate is only 27% there. So you have 6,000 patients in one hospital, 550 dead, 3,800 doctors are dead, about 18,000 healthcare workers are dead. When will this damn population wake up? So since I have the opportunity for the mic, I'm venting because I'm really pissed off. Very sad.
So one government, somebody commented, one government doctor got a lung transplant in India. Somebody commented on. So
Yes, sir,
Columbia
it's
University.
me, sir, Dr. Naveen. It's me, Dr. Naveen, sir.
Go ahead.
In
Dr.
government,
Naveen,
in AP it happens, sir. In AP it happens.
Yeah.
In AP.
So in University of Pittsburgh did about a dozen transplants. The first 2, 3, they struggled with it. They couldn't pick a case well. They're more comfortable in doing them. University of Pennsylvania is doing them. I think each has done about 10, 12 cases. But they're very picky about what case they do. They're not enthusiastic about doing them yet because obviously there are lots of, before COVID came, there's so many people on transplant lists and all of them have been bumped. They're waiting for their transplant desperately ill. So there is some ambivalence about doing COVID-related lung transplant right now because you got to take care of the groups that have been waiting before COVID came. Sudhakar, you have any questions?
No, I've been listening, and everything seems to be perfect. And Venkatram has done a great job. You may.
So Venkatram, would
Yeah.
you? What's your what would you recommend about flu vaccines this year? Now that you showed data that's worrisome when you have COVID and influenza, are you recommending flu vaccines now?
Yes, I think we should not change the way we practice prevention. I don't know how good the flu vaccine is going to be because it's based on the trends of the last year. Since we don't have much trend for the last year, I wouldn't know how good this is going to be, but I think an ounce of prevention is better than a pound of cure. I still think we should get our flu vaccinations. And I do hope that this vaccine is a better fit than last year. So at least we can eliminate some influenza infections. And I think critical care needs a break. So I think, maybe this winter is a break for us.
Prem Kumar, are we seeing RSV infections in India, an increased rate of RSV infections?
Hello.
Yeah, we can't hear you.
Dr. Chilamuri, can you ask me again?
So the question is RSV infections. Are you seeing a higher rate in India this season?
Actually, we don't know whether it is RSV or influenza or what, PCR and all won't be done. But definitely this season we are seeing a lot. Right now we are seeing a lot of flu cases. And I sent around a dozen to RT-PCR to SRL Mumbai, which came as H3N2.
Okay.
But I don't know about this respiratory syncytial virus. But one question I was, though you said no therapeutics, I'm just crossing my border.
Yeah, go ahead. No, we'll answer. I
Dr.
said no
Chilamuri.
need to talk about it, but you're happy to ask questions. Sure.
Right. A recent New England Journal of Medicine has published that the monoclonal antibody cocktail makes a difference in hypoxic patients who are seronegative. So can we do that? Or are you practicing that doing IgG, IgM, and in seronegative patients, though they are hypoxic, can we get monoclonal antibody cocktail?
So we have not because the FDA is waiting for the FDA to approve that indication. And if they do, we will give it. So we started the practice of as soon as a COVID positive patient comes in to immediately obtain both spike and nucleocapsid antibodies. That's our standard of practice in preparation for this monoclonal antibodies to come. But the FDA still hasn't approved us for that indication yet. So I saw the paper and we're waiting to see why there was a delay in approval for that particular indication.
Thank you.
But I think you could try it if the person is not hypoxic. If the antibody is negative, it's worth a try. But we've got to make sure they're not hypoxic at that time.
Thank you. And did you make any? Did you see any difference between this? I mean, apart from the huge number of case load, any difference in severity or mortality in Delta?
Venkatram, you want to comment on it, or you want?
No, actually, in critical care, we haven't seen an increase in mortality due to Delta. No, we haven't seen. It's behaving exactly the way maybe the mortality now in the ICU is probably not really Delta related or something else. I think it's because of better understanding of the disease, more use of non-invasive ventilations, more use of high flows, more use of other medications, especially dexamethasone and other ancillary therapies. Toci we are using, we use a lot. So I think that is what is decreasing the mortality. For certain, we have noticed a huge decrease in mortality compared to what it was in the first surge.
Dr.
Yeah,
Venkatram, how many cases? Okay, please go ahead.
Yeah, there have been comments that maybe the Delta variant is more severe in the data from UK and Singapore seem to have suggested that. But in the US, we are not seeing that. It behaved exactly like just more number of cases, but we are not seeing it any worse than the previous variant. So I wouldn't say it's more virulent.
Dr. Venkatram, how many cases of vaccinated people landing up in ICU in your
I can think so far I have been taking care. I have been in the ICU for the last 2 weeks, and I can tell you, I am yet to see a patient who was vaccinated who came to the ICU. But I did take care of one patient in the floor last month who was vaccinated, but was admitted for hypoxia, recovered, and went home.
Yeah,
but everybody else is not vaccinated.
Yeah, we have 26 vaccinated admitted patients, out of which one went to ICU and recovered completely well. So generally, I would say vaccinated patients do well. We had no mortality at all with vaccinated people who developed moderate to severe illness. So that's our experience so far. The numbers are growing up. Currently in the hospital, 30% of admitted COVID patients are actually breakthrough infections. So that breakthrough rate is going up.
So you mean to say that the efficacy of Pfizer vaccine is falling? Because in Israel, it is said initially it came down to 67%, and now 2 weeks later they said it is 39% only.
I think it is falling, and that's why we started booster doses. Yeah, I think so. The majority of our breakthrough infections have been Pfizer, and followed by Janssen, and followed by Moderna. So I think Moderna had the least number of breakthrough infections so far. I'm talking about admitted patients. We do get a lot of breakthrough infections in the outpatient world, but they're generally very mild and don't require any medical attention. Yeah, so Pfizer's vaccine does wane after some time.
And here we haven't seen any multi-system inflammatory syndrome, adult or, the with vaccine-induced thrombocytopenia. What's your experience over there, Venkatram? MESA.
I'm not seeing that much of multi-system involvement now. We are seeing predominantly respiratory involvement. Yes, we did see a pulmonary embolism here and there. The biggest good thing that we have seen this time is the number of acute renal failures have definitely come down compared to the first surge that we had. And the number of hyponatremic cases that we were seeing in the first surge, that's down. We don't see that. And we are not seeing any strokes. I haven't seen any strokes in the last month and a half. But we did see quite a few strokes in the first surge. So it's moving away. It's more behaving like a predominantly respiratory pathogen. Multi-system, thank God it's not there. That's maybe
so
good
in
news.
Texas, where they had the big wave of infection, they saw Miss-C actually. In children, they saw a fair number of, Baylor admitted nearly 26 kids with Miss-C. But we're not seeing any Miss A anymore. We're not seeing it in adults. Very little with Delta. I think it's in kids. In kids definitely did it in Texas and Florida. In New York, we're not seeing any of that right now. In New York, it's quiet right now.
Dr. Sridhar, I had a doubt quite for some time, and today I'm asking you. See, steroid we should not prescribe unless there is hypoxia, or steroid should not be prescribed early on because probably for the fear of increased viral replication and all. Keeping this in fact, those people who are already on steroids for various other indications like, and if they catch infection, that means that they're using steroids in the beginning. So what will happen to them?
So we're still collecting that data, but here's if a person is already on steroids, and when I say steroids, at least 20 milligrams of prednisone, for whatever reason, because he has asthma, because he has lupus, whatever reason they're giving him steroids. If it's 20 milligrams and you catch COVID, they do very poorly. They actually die. It's a bad prognosis. We've seen that in transplant patients. We've seen in patients who get chemo. So I think if you get COVID while on steroids, it's not a good news. So that is still the problem. That's why people with lupus, inflammatory bowel disease, before the wave starts, and if you are in situations where it's soon coming to you, we tell them get vaccinated as soon as you can, number one, and see if we can wean you off steroids and use biologicals. You can use TNFs. And it's, for instance, in inflammatory bowel disease, somebody has Crohn's disease, you want to take them off steroids, use Remicade or any of the TNF inhibitors, vaccinate them as soon as you can, so that you won't end up in a situation where they get infected while they're being treated with high doses of steroids.
Thank you so much.
Any other question on anybody's hand up that you saw that I didn't see? All right. Okay. Anyone has any other questions? I think we're done, Venkatram. I don't think we have any other questions. Sudhakar, you could, if you choose to, we can end it now.
Thank you very much, Venkatram, and Prem Kumar, particularly for such a nice discussion. And yeah, Sridhar for so ably conducting the proceedings. And as usual, Ram Mohan has raised a lot of concerns for the public behavior, as well as the way that we are going forward. And I'm sure that with weeks to come, probably we'll become more wiser. And probably we have to have somebody in the United States and southern states to have public figure to tell people as to how they should behave and all. When Ramohan tells us every time, we are trying to do our best here. I'm going to the village press, educating the people the importance of wearing masks. And with that note, I thank each one of you very much, and let us meet again next week at the same time. Thank you. Bye-bye.
Dr. Venkatram, thank you very much for doing this again. Much appreciated. Thank you.
You're very welcome. Thank you. Thanks, everyone.
Thank you, Venkat. Thank you, Prem. And bye-bye, Ram.
Thank you, Sridhar. Thank you, Venkatram. Thank you.
Okay,
Okay,
good
bye-bye.
morning to all of you.
Good night.
Bye.